Welcome to the Learn Skin podcast with Dr. Raja and Dr. Hadar, where they discuss all things skin. Skin is fascinating because it affects us in so many ways, like our health, psychology, and how we connect with those around us. This podcast delves into the art and science of skincare. A short disclaimer before we get to the good stuff. Dr. Raja Sivamani and Dr. Hadar Levtov are board-certified dermatologists. This podcast is meant for educational and informational purposes only. All opinions shared do not express the views of Learn Skin. Neither this podcast nor any information contained within it are a substitute for professional care by a doctor or other qualified medical professional. This podcast does not constitute medical or other professional advice or services. If you have a medical concern, please consult with your physician.
Hey Raja, how are you today?
Hey Hadar, I'm looking forward to another episode together.
Well, we are in luck because we have one of the best in the best. We have Dr. Peter Leo with us. Should we introduce him?
Yeah, let's do it. Dr. Leo is a good friend of ours, inspirational dermatologist, integrative board-certified dermatologist, and he is an expert in eczema. We are talking integrative approaches to eczema today. So really excited to have you join us today, Peter.
Thank you guys so much for having me. This is my favorite thing to talk about, so I'm in the right place, I think.
Okay, so let's do it. You know, I think that we keep talking about integrative dermatology in the context of integrative medicine, but I think eczema, more than any other condition, probably suits right into that definition. Do you agree?
Very much. I think it is sort of the perfect storm for patients wanting to seek it. And in my mind, I think there are three major areas that will drive patients to seek alternatives. You know, one of the things we know, being, of course, Western trained, is that for a lot of things, we have a really good answer. And I don't think patients are going to be seeking alternatives for things that we can solve very quickly. So for example, if somebody has an open fracture and is bleeding, nobody is saying, hey, can somebody get a Reiki expert to help me? If somebody has a terrible strep throat, they're not saying, why don't we, try some meditation practices here? It's like, no, we kind of have those things solved in a way that I think most people will seek it out. But when diseases are not curable, when our explanations are unsatisfying, and when our treatments are felt to be unsafe or only symptomatic, those are kind of the three that I carry with me that I think are really good signs that people are going to go out of the standard rubric. And atopic dermatitis typifies that all three counts.
Peter, you made mention of something that I think is really important. You said when diseases aren't curable, especially when you're thinking chronic. Just my personal experience, even coming from an Ayurvedic medical approach, combining with Western medicine, I know a lot of patients want to look for a cure. And my conversations to them has always revolved around, well, what does cure actually mean? And I feel a lot of that actually looks at lifestyle changes or something that you can put in as a constant habit that you do over a long time that helps to control and manage eczema. I'm curious how you approach patients when they come in and ask about a cure.
I think you're right on. And I always think of the words of one of my teachers, Dr. Richard Johnson, who used to say to a patient when they'd say they wanted a cure, he would say, no, we never cure, we only treat. And I thought that was interesting. You know, he was very seasoned even back then. He's been in practice for many years, but I think he saw it exactly as that we're not going to be able to cure too many things with one shot of penicillin. There's a few things, of course, that will be cured, but other things really can't be. So it's going to be a process. In a way, these chronic diseases that really we see so many of in dermatology, that's a lot of our bread and butter. It will take a series of things from drug treatments to lifestyle treatments to really changing the body over time to get to a place I think many people can get to, a state of deep remission or a much better compensated state. But even for the patients that I think haven't had trouble in a long time, you will see lapses. Things will happen where they'll say, oh, I was doing great for many months and then I got sick and my eczema flared up again. Or I traveled and I hadn't seen anything going on for a while, but I accidentally used a soap in the hotel and oh my gosh, my skin is on fire. So even when they're better, or in a relatively cured state, I think we see those primary deficiencies, some of which we know are genetic and constitutional, if you will, of those patients. They can then rear their ugly heads in the future.
And another reason I think eczema really fits in with integrative approaches is because eczema, which is different than many other diseases we treat, is a disease of the family. So most commonly affected are kids, and then the parents and the siblings, and even goes into the school, the teachers, anybody else that comes in contact with a child with eczema is pretty much affected. So I think the integrative approach that takes into consideration the entire human being with the environment around him is really applicable.
I think that is so spot on. It is really, the suffering is shared by the entire family unit and social unit. So I totally agree. And I think that second point about our explanations being unsatisfying is really important too. And I think a lot of patients are drawn to alternative forms of medicine because sometimes the language people will use in both understanding the condition, but also in terms of getting to a state of better health, are much more appealing. And we look at what we tell our patients with atopic dermatitis. Why do I have this? Well, I don't know, genetics, environment, maybe it's the hygiene hypothesis, you were too clean, maybe it's somehow related to having allergies in the family, there's sort of a hyperactive immune system. It's very unsatisfying. But whereas if you were to say something along the lines of, oh, you have leaky gut, it's sort of a unifying concept. Patients like that. You can kind of put your hands around it and say, okay, I get it. My gut is damaged. I got to fix my gut. We now have a plan of attack. So I think Western medicine shines when we can give people, any medicine shines when we give people a good understanding of the process of the disease, and we fail when we can't. So for atopic dermatitis, we're still obviously in these kind of early stages. We're learning more and more about it, but we have a ways to go, and there's a lot of conflicting advice and information about what's going on. And I think we can see a better story in traditional Chinese medicine and Ayurvedic medicine. I really like some of the language around it. And then even the language to getting to health, I try to borrow from my alternative medicine tradition, particularly, I was trained in acupuncture. And I love some of the terminology. For example, a term that almost never will come out of the mouth of a Western trained doctor is the concept of tonifying, right? Strengthening the body, right? We don't talk that way normally. It's like, we're gonna cut this out of you. We're gonna blast that infection. We're gonna poison the cancer, kill it, destroy. That's very much this bellicose language that we use in regular medicine. But in alternative forms of medicine, I think we focus much more on building up the patient, strengthening, balancing. And these are important terms, not just for some, namby-pamby wanting to word it in a soft way, but I think they're really important for this condition too, because this is, in my opinion, a condition all about imbalance, that the body's out of balance. So if we're not thinking about balance, we're just thinking about kill the staph and knock down the inflammation, I think that we're only, nipping at the heels of the true essence of the problem.
So going along with that, when we're thinking about an integrative approach, you make the comment that not only is an integrative approach reasonable, but in some patients, it may be superior for many different reasons. Can you talk about what does an integrative approach to eczema look like? What does that look like to a patient that's coming in and getting treatment?
Absolutely. To me, what I think of when I think of integrative medicine is taking the best of any worlds, okay, in all the worlds. So taking the best conventional approaches and weaving them together with complementary approaches from different traditions in a way that is coordinated and that we're all comfortable doing. Now, that is a very personal definition because my comfort zone is very, very unique to me. I know a little bit about traditional Chinese medicine through the lens of acupuncture, but if you start talking about advanced herbal treatment, you've lost me. I don't know. I'm not comfortable doing it. I don't speak the language. I'm not going to be able to take someone all the way down that pathway. And equally, if we start talking Ayurvedic medicine, I've learned from you, Raja, on even listening to the podcast. The last podcast that I listened to was you guys discussing Ayurveda, and I thought it was so wonderful to think about these structural concepts. So I feel that I can use some of these ideas, but again, I couldn't give somebody a prescription for a lifestyle change or an herbal change based on that tradition alone. So each person, each practitioner kind of has to find the pieces that they can take from each area and weave them together. And I've kind of found for myself a pretty neat little zone where I know a lot about the Western treatments, everything from the basics of moisturizers and topical corticosteroids and non-steroidals, all the way through the systemic immunosuppressants and the fanciest new biologic agents. So I feel very comfortable with that armamentarium. And then selecting things from different traditions that I'm comfortable with, everything from different acupressure points that I can have the patients do themselves at home to different topical herbs and botanicals that I feel comfortable with, both in terms of how they're going to react with most patients, but also sourcing them, because that's another very practical kind of nuts and bolts problem. It's like, well, I want to try, coconut oil. Which one should I pick? And if you go to the grocery store, there's 20 brands, or you go online, there's hundreds of brands and hundreds of preparations. And And this is another problem that part of that is solved as you become more comfortable and confident in an area and get experience. But obviously you can't be experienced in everything. So to come back around to the question, I think that this is a disease, a condition that really responds well to bringing both sides in. We can do some of the stronger conventional treatments, but we can then take from different alternative traditions and bring them together to strengthen, rebalance, and fortify the patient. And I think when we do that right, I truly believe that we get a better outcome than doing just one path alone.
Thank you. That was a great discussion. I wanted to ask you, because you've been touching around this, but I would like to ask this in a more direct way. We explained why for many patients, the integrative approach may be more attractive. Why should any practitioner, a dermatologist, a primary care doctor, treating a child with eczema or even an adult with eczema, why should they try to pursue the integrative approach? If you can really sharpen that argument for them.
I think here's the question I pose to anybody who questions this and says, "What, you're wasting your time. Why are you looking in here?" I would just say right back, I would say, do you want a great clinician? And if the answer is yes, and I really think that most of us are drawn to medicine because we want to help our patients, we want to be great, we want to keep learning and growing. If you really want to be great, then you have to open yourself up to anything and everything that could potentially work. It is tempting to simply want to close the door on huge areas that are overwhelming. You know, when you start going in an alternative world, it's pretty overwhelming. There's tons of studies. A lot of them are somewhat low quality. They're often small numbers because they don't have the kind of funding or controls that we might see in, for example, a drug company funded study for a FDA pivotal trial or something. And it can just be confusing and scary and overwhelming. It's easier to close the door. But if we open that door, I think we can then say to ourselves, look, we don't understand, we could argue we don't understand how anything really works, right? We have working definitions, operational definitions of the way we think things work. And we know every 10 to 20 years, most of that is outdated anyways. But even if we don't have a specific mechanism of action that fits with our worldview about why an herb might work or why a mind-body approach might work, if we feel that there's evidence that it can help the patient, then in our attempt to be a great clinician, we're going to try to bring that in. We're going to try to use that even if we don't necessarily know why it's helping. And I feel strongly about that. So I think that's the kind of soul searching each clinician has to do. And when people react very harshly to it and get very defensive, it's very akin to scientism, where people sort of say, nope, there's no such thing of anything outside of regular science. Physics is king, and you can't break the laws of thermodynamics, and we know it in 100%, and this is the way it goes. And it's like, well, if you look around the late 1800s and early 1900s, people were saying very similar things. They were saying there is nothing new under the sun. Physics has solved everything. All we have to do is find the details, until people started playing around with some of these problems like black body radiation, where they said, conventional Newtonian physics doesn't explain this. And suddenly, of course, that opened up an entire new shell of understanding and reality in thinking about quantum mechanics, which changed the world. But we're still kind of reverberating from that change. And I think that we haven't all embraced that or adapted to that new world of quantum mechanic understanding. I'm getting out there, but I feel that it's so important.
No, I love it. Keep going.
Right? Because we have this, it's just so similar. Obviously, it's not the same thing, but it's an analogy to the way people will get about medicine. Well, this is how I learned it, and this is the way it is, and all the rest of stuff is bunk. And it's like, well, we know that everything we've learned gets outdated every few years. So how could you close the door to it? And I think my impassioned plea is to keep your mind open and keep looking for some of these things that are working, these signals, because that's the only way we're going to be able to study them properly, bring them in properly, and vet them so that we can take things that are outside of conventional medicine, study them, and approve them so they can become part of it. Because, right, the best form of science, the best form of conventional Western medicine is the form that says we're open to anything, we're open-minded, and we're going to rigorously test it to see if it works. So if we don't have data on something, it's weird to say that, oh, it definitely can never work. The only thing we could say is, look, we don't know yet. We don't have much data. And what I'm interested in is starting to mine these areas that you start looking and you say, hey, you know what? It's not true. It's not true that there's no data. Actually, I have a couple of really good studies on this. For example, coconut oil. I can show you pretty convincingly that it has a positive effect on patients with atopic dermatitis. I can show you with pretty good evidence that it kills Staphylococcus aureus. That's not nothing, right? That's something. Now, it may not be to the level we want it. And of course, we know Carl Sagan makes the point, extraordinary claims require extraordinary evidence, but we have to take a moment and look back on that, because how we define extraordinary really depends on who we are and where we're coming from. What is extraordinary to that person over there may be commonplace for us. We see this all the time. And therefore, this is kind of a biased way of looking at it. When will you be satisfied that there's enough evidence to use this? The answer for some people is never. You're never going to be convinced because they think it's all hogwash. So I kind of have to navigate these worlds, and sometimes I'll give a lecture to a group of very sympathetic clinicians who are excited and asking questions and pumped up by it and want to learn more, and they kind of feel like this is amazing. And other times I'll have a skeptical group who sort of says, well, this is a bunch of baloney. In cardiology, we have studies with N's of 13,000 patients, and you're showing me things with 13 patients. But on the other hand, this is sometimes all we have. And as clinicians, we're used to working in this world. Most of the things we do in dermatology have relatively little data, and there's an awful lot of art to a relatively small amount of science for most of the history of our field, which I'm proud of and excited by.
Peter, you really hit this nail on the head. I can't agree with you more in terms of just how you're talking about how we think about evidence. One small example, even within Western medicine, we have a lot of gray area decisions that we need to make where we don't have very good evidence. And it sometimes defies logic. And one of the example is that I had a patient that had eczema, and we treat with topical steroids as part of the regimen. And one of the steroids wasn't working, and it turned out it was a class 1. I had given the patient a class 1 steroid, which is the strongest steroid. And I thought, how can this not be working? I said, what does work? And they mentioned a class 4 steroid instead. And they said, no, that one works, and it works stronger for me. And I'm thinking, wait a minute, you look at the logic, and it should have been the stronger steroid is going to work better, theoretically speaking. But there was something for their body that wasn't working. It was the other steroid that was working better. And I kind of had to say, well, you know what? Logic doesn't matter when the patient's having a response, because that is the at the end of the day, the goal is to get them a bit better. And so then I had to set aside my logic and say, okay, well, if this one works better, I'm going to prescribe this. And of course, build in all the other things that I build in. But I think that even within Western medicine, we see that we have to make these gray area decisions in the rooms all the time. So I really appreciate you making the comment about integrative medicine, taking together not only what we find in conventional medicine, but the idea that there are other things that can be integrated in. I'm hoping that one day integrative medicine will just become medicine, and we won't have to use the moniker integrative. But I think integrative right now obviously means something. It means that we're thinking conventional and trying to bring in things from maybe that aren't so conventional yet or haven't gotten there yet.
Yes, Raja, thank you for saying that. I agree. I think that everything is on a spectrum, and that's how I explain it to other physicians who ask me about these approaches. To me, everything is on a spectrum. It's just a matter of evidence. If you have strong evidence for something, immediately it becomes mainstream medicine. But if you don't have enough, and maybe there's not some other strong incentive for this to become part of the market, then it just stays sort of, as an alternative approach. The other thing I want to say is that one thing I tell other physicians is, in residency and maybe early, you see a patient once or twice, but what happens when it doesn't work? Like Raja just gave an example. Sometimes things don't work, and then you have to go outside of your comfort zone. So sometimes you can refer, but that goes back to your idea, Peter, of being a great physician. Maybe sometimes you just have to go outside of your comfort zone a little bit in a safe way and go try something that you are not comfortable using. But that brings me actually the whole discussion of going outside of your comfort zone and the need for evidence to the point about side effects and safety, because that's really an important concern that both parents have and other patients and other physicians. So maybe, Peter, you can tell us a little bit how you approach safety issues when you try things that don't have, the study with 13,000 subjects.
Absolutely. And that's definitely the world we live in every day with, relatively small amounts of safety data and, efficacy data as well, of course. So I think there are 3 filters that I apply to my view of integrating things from outside of the conventional canon. And the first is we have to have some data for its efficacy. If there's really none, I might say, well, I just really, as far as I could tell, there's really nothing about it. If somebody says, I found some plant in the yard, and I have a sense or an instinct that this will help me if I rub it on my skin, should I do it? I just don't know. I don't even know what the plant is. I can't help you there. But if we have some efficacy data, the second step is we really do want to see some safety data, even again, if it's modest. Most of the botanicals we're using on the skin have been used in other contexts too. So we're relatively backed up with that. Even if they haven't been used for atopic dermatitis in this particular patient, we often know they're used in other contexts. Many of the things we use are food products as well. So we have some sense of their safety, but that's important. And again, if we really didn't know, I might be more hesitant. If I said, boy, we've never ever looked at this, we might want to wait. And then the third piece is the practicality. And that's, for me, the biggest burden, and something I keep wanting to stretch myself to get bigger and better in terms of what I can practically utilize. But that includes things like sourcing herbs or doing even things like mind body, where I need to have the patient work with a practitioner who's very good at it, or try to find time to teach them some of the modifications and behavioral things that may help them. But that can be difficult, time consuming, and requires sometimes expertise outside of what we can provide there, and sometimes even financial restraint, because if you have herbs that are good but they're very expensive, this mostly are out of pocket costs. The patient might say, gosh, I'd love to pursue that, but I just can't. And I do have patients where unfortunately the financial constraints are a limiting factor, because as we know, our insurance covers generally only conventional treatments. So those are kind of the three filters that I'm applying when I'm looking at these things, and the safety is certainly one of the key pieces.
That is excellent. Thank you so much for reviewing this, giving us a framework on how to think about trying new things in the context of safe interventions. And speaking of trying new things, maybe we'll go to some examples. Perhaps you can kind of whet our appetite with one or two examples of interventions that you commonly use in your office for patients with eczema that, the run-of-the-mill dermatologist or pediatrician may have not thought about.
Absolutely. And I've kind of invoked it a few times, coconut oil. And sometimes it gets made fun of, because I think a lot of our patients are talking about it, and many people sort of view it as a panacea. It's like, I had a little rash, I put coconut oil on, it got better. I have acne, I put coconut oil. It may not be
Absolutely
for those things, right? As we know. But I will say, for atopic dermatitis, I do like coconut oil. I think it's really can be a nice ally for many patients. It's lightweight, cosmetically elegant. It has a lot of medium chain fatty acids, which are really kind of nourishing and soothing to the skin. It has been studied in patients with atopic dermatitis. It seems to be a very good emollient. It seems to have some ability to cool the eczema severity down. And then most importantly for me, because the patients I pick it in are those that have recurrent staph infection or heavy colonization, it seems to decrease the staph, which is really powerful in a non-antibiotic way, in a way that presumably is not going to be easily worked around by the bacteria. We don't think or anticipate there's going to be much resistance to it, because a lot of the botanicals work in multiple ways at once. So that's one. And of course, we're going to be talking about it in much more detail in the future. We can go into the studies and really get into the brass tacks of it. The second one is even a little bit more out there, and that's topical vitamin B12. Topical vitamin B12 has been actually studied in a couple of really well orchestrated trials that shown in a randomized controlled fashion that it seems to decrease the severity of atopic dermatitis compared to the placebo. And what's remarkable is that it seems to work by blocking nitric oxide synthase, which is one of the things that can start a flare. So it may have kind of a prevention effect. And the way I like to use it in my practice is I will use topical corticosteroids to cool their flare up down, get them better, maybe do it for 5 days a week, get them better. But then for those patients in particular who say, as soon as I stop, I flare up again, they can then switch to a topical vitamin B12 preparation twice daily, and that seems to prevent the flare-up. So I use it as a steroid-sparing agent to increase the interval between flares and therefore decrease their overall corticosteroid use. What's remarkable here is that the data is really high quality. It almost looks like they were going to submit it for FDA approval, but maybe because it's so inexpensive and widely available, you can have it made for maybe $10 or $20 for a patient, that they never went forward with that. But those are two interesting things that I use. And of course, I have a little notebook of about maybe 10 to 20 things, depending on the situation, that I would love to explore with you in more detail in a future test.
That was really, really interesting. And I'm curious to hear more about how you use these even specific interventions on which patient, and side effects, and how you answer questions, and how do you even get those creams. But since we want to have a very elaborate discussion, we fashioned a whole different context for this in the Integrative Dermatology Symposium. That's the one coming up in October. And I believe you will be there. In fact, I know you will be there. And I know that not only you will be giving one of your spectacular talks, you'll also be running a session that is case-based discussion about eczema. And you will be interviewing and discussing these case management with a bunch of other clinicians, maybe from other disciplines. So I cannot wait for this incredible discussion.
Me neither. I can't wait. It's going to be an amazing symposium. If it's anything like last year, and I think it's going to be even bigger and better, we're going to have a great time, and there's going to be lots of learning and lots of sharing between everybody.
And Peter, can you explain what we might be talking about? Because one of the things that we, as clinicians, really feed upon is clinical experience. And I think talking about the studies and whatnot is obviously very important. It's as all the researchers in us really care about that. But the clinicians in us want to discuss these cases. We want to see how other people approach cases where we've had some challenges or we've had some restrictions or there's those unique characteristics in a particular case that we want to figure out how did other people do it. And what do you think is going to be the gain out of going through these case-based discussions? What was your hope that we'd get out of that?
I am really trying to provide a toolbox that everybody can keep with them mentally that are going to be accessible to any tradition. Because one of the coolest things about this Integrative Dermatology Symposium is that it's not just dermatologists. It's people from different traditions, different specialties, but also totally different traditions like traditional Chinese medicine or Ayurvedic practitioners who are not even able to necessarily write a prescription strength corticosteroid or a calcineurin inhibitor. So I'm trying to develop a toolbox that anybody can use that has been vetted to a certain extent with some evidence, some safety data, and then my clinical experience. And then my hope is that we can keep growing that. We can all contribute to this toolbox. One of the things I've been working on for a long time, that little preview of the talk, is can we to a certain extent, simplify some of the traditional Chinese medicine diagnostic terminology to fit at least a couple of our common clinical patterns of atopic dermatitis. And if we could do this, even in a few cases, even in just sort of a few classic cases, if you will, we may be able to make a simplified herbology too. So this is one of my longer term products. Can we sort of simplify things a little bit so that things are more accessible for everybody instead of having to go all the way deep into the weeds to do that? And I think that's part of the longer term goal, this collaborative goal of getting all the specialists and all the different traditions to work together.
Deep into the weeds. I love it. One of the things, Raja, that I think about advantages of case-based discussion is, like you said, I read the literature, but sometimes when I see a patient, it doesn't really necessarily fit one of the criteria that were in that study, or the patient doesn't really fit perfectly the entire regimen that was prescribed. So I need to adjust. And also, it helps me remember, because when we talk to each other, a lot of times we talk about cases. We talk about that patient that I had in residency, right? We all remember that patient, and that's how we learn. And a lot of this stuff is not in a textbook. And that's why I think having case-based discussion as part of the meeting will be so enriching, especially when we talk about integrative approaches that can be complex and involve multiple practitioners treating the same patient, but also where not a lot of this stuff is in a textbook somewhere.
Yeah, that's exactly right, Hadar, because I think when you start thinking about how other people might approach a given case, you might start to see that, hey, maybe there's a community around me. I don't have to do all of this by myself, or at least I can educate the patient on other approaches that might be working synergistically. Well, this has been a really exciting session. I think it opens up a lot of excitement and questions, and for me, anticipation about learning as much as I can as we go along. And I want to thank you, Peter, for joining us and spending some time with us on the podcast to take us through your integrative approaches to eczema.
It was a pleasure. Thank you guys for having me.
Thank you, Peter.
Thank you for tuning into the Learn Skin podcast with Dr. Raja and Dr. Hadar. We would like to take this moment to tell you about our upcoming second annual Integrative Dermatology Symposium to be held at the Coronado Island Marriott in San Diego, California. This program will be 3 days of jam-packed information, including case-based discussions and multiple perspectives on topics such as psoriasis, atopic dermatitis, diet and the skin microbiome, cannabinoids, hair loss, traditional Chinese medicine, and much, much more. Go to www.integrativedermatologysymposium.com and register by July 31st, 2019 to take advantage of our early bird special. We look forward to seeing you there.